now Dr. Ihab Atia, Professor of Cardiology, Faculty of Medicine, Ain Shams University. Hello, Doctor. How are you?
Hello.
What's new in the management of dyslipidemia?
When we talk about dyslipidemia, we talk about what's known as new concept, residual risk. Residual risk means that we have our patients who are at high risk for getting heart attacks, and we are giving them all the classical medications. People know them by the name of statins and other tablets. But despite all of that, they don't reach the target that we expect, because we expect to lower the bad cholesterol, which is called the LDL cholesterol, below a certain figure. For example, it's a 70 milligram per deciliter. And if we don't reach this figure, the patient is subjected to what's known now as residual risk, meaning that he will keep getting repeated heart attacks, repeated strokes, despite taking all the tablets that are available to us. So, to solve this problem, they found out that we need to lower their bad cholesterol with newer modalities, therapeutic modalities. And science discovered what is known as monoclonal antibodies. Monoclonal antibodies, it's an antibody that targets a special protein in the liver that blocks the liver from removing excessive cholesterol. So that antibody prevents that block. So it maintains the liver's function to get rid of the excessive cholesterol in our blood, the bad cholesterol. So this is the idea behind these monoclonal antibodies, and they are not tablets. They are taken by injections, what we call subcutaneous, beneath the skin. Every 2 weeks, you give an injection every 2 weeks, and it lowers the bad cholesterol to really very low dramatic figures. And there's a large study called the Fourier study that was published in last March, and it showed that these drugs lower cardiovascular events, myocardial infarctions mainly, and not only that you lower the cholesterol, but you lower the clinical events. And so this was the first time we get evidence from these new drugs, and this is why now the guidelines all over in Europe and the States are starting to incorporate these drugs to be added to high risk, not everyone, it's for high risk categories, mainly familial hyperlipidemia, because we have a lot of families, for example, in Egypt and all over the world. You have the brothers, the sons, daughters, they inherit the genes of high cholesterol, because there is a misconcept in the people's mind that cholesterol comes from eating too much. This is not true. Eating and diet is responsible for a small amount of our LDL, bad cholesterol in the blood. The majority comes from genetic predisposition. And it is very difficult to treat these genetic predisposition with the regular tablets. So with such new agents, you can lower the bad cholesterol in these familial hyperlipidemia. The other group of patients that will benefit are those, like I said, who are at high risk. After taking the regular tablets, they are still suffering from high cholesterol, so they will need this drug. And finally, it's a third group that is called statin intolerant, means they cannot tolerate statins. You know that statins, not everyone can take them. A lot of our patients complain of muscle pains, myalgias. Some of them have elevations in liver enzymes, and they cannot take these drugs. So there is an alternative now. Alternative is these new agents. So that's really something new, and it's the first time in 2017 that we get evidence that it is beneficial, and we expect more evidence by the end of the year.
Okay. And finally, how can we help our cardiac smoking patients?
Our cardiac smoking patients are a real problem, because they are addicted to smoking. It's not a habit, it's an addiction. And what made it worse nowadays is the presence of what is known as electronic cigarettes, the e-cigarettes. That you find everybody's holding an electronic cigarette. So if we're talking about classical smoking, what we do as cardiologists, we have to advise them to stop smoking. We have to help them with some of the medications that will allow them to get off the smoking habit, and there are these medications, we can refer them to smoking cessation clinics, and there are special, about 5 or 6 in Egypt, specialized smoking cessation clinics, and we keep monitoring them in our visits to ask them if they stopped or not. We can encourage them, motivate them by explaining the risks to them, to their families, especially the new habit of the shisha smoking, because they think that shisha smoking is less harmful. It is not less harmful. Actually, it's quite harmful, the same as the regular cigarettes, especially if you stay, for example, in a cafe for an hour.
Oh, yes.
It's like you smoked 200 cigarettes during that hour.
Okay, so
Because,
it's
you know,
worse.
the workers in this cafe keep renewing the tobacco in the cones of the shisha repeatedly. So it's really harmful, especially for the youth who think it's fashionable. They go out with their friends and they tell you, I'm not smoking, I'm just having fun with water pipe or shisha. This is a serious problem. Another thing is the e-cigarettes that I said. E-cigarettes, the problem is they have ingredients, chemicals that help to make the nicotine liquid so that it can be burnt by the battery inside the e-cigarette. And these liquids, a lot of them have carcinogenic materials. They can cause cancer. And they are being marketed now by some of the, I don't want to say names, the tobacco companies are starting to produce them. So it is not safe. It does not help you stop smoking like they mention at all. And in addition, there are new harmful agents introduced besides the nicotine. We're getting carcinogenic material. So we have to get the message out that e-cigarettes is also harmful and should be stopped. And it's not going to help you stop smoking. If you want to stop smoking, you either see a physician or one of the smoking cessation clinics that are available. There is a number, it's a number, they can call a number, it's 16805, and they will refer them to one of these smoking cessation clinics to help them if they really want to stop smoking. But this is how we can help. Like I said, to advise and refer and monitor, keep monitoring our patients.
Okay. Thanks a lot, doctor.
Thank you very
Thank
much.
you.